our next speaker will be Professor Jia Feng Wu. He is a professor at Department of Pediatrics, National Taiwan University at Children's Hospital in Taiwan. Today, he's going to give us a talk on endoscopic management for foreign body ingestion. Please welcome Dr. Wu.
I'm Professor and colleague. I'm Dr. Jia Feng Wu from National Taiwan University Children's Hospital. It's my great honor and pleasure to be invited to the first APPSGHAN Endoscopy Masterclass. Today, I would like to discuss with you about endoscopy management for foreign body ingestion. This is my disclosure. Foreign body ingestion is quite common in the GI clinic. The majority of foreign body ingestion occur in the pediatric population. 98% of foreign body ingestion are accidental and involve common objects found in home environment, include coins, toys, magnet, and battery. Children with foreign body ingestion may be asymptomatic or present with overt symptoms, such as stridor, pain, fever, crying, dysphagia, respiratory distress, and even shock. Most ingested foreign body may pass spontaneously, but 10 to 20% of foreign body ingestion may require endoscopy removal, and less than 1% will need surgical intervention for the removal of foreign body or the management of related complications. This is a large retrospective cohort from Germany. The data show us that the most common foreign body in Germany include coin, metal, button battery, and also food. From this case series, 10.5% require intervention and 0.33% require surgical intervention. But surprisingly, the annual foreign body ingestion-related hospitalization rate increased significantly in recent years. This important data shows us that foreign body ingestion in children remains an increasing medical issue in the field of pediatric GI. Initial assessment is very important in all presenting cases, but should not delay the urgent treatment. We need to offer this patient precise history taking and also physical examination to confirm the type of foreign body and the time of onset. For radio-opaque object, we need to arrange plane or biplane radiography to locate the foreign body and to exclude the possibility of complication. Contrast studies should be avoided because they can delay the treatment, impair visualization of the endoscope, and even worsen the complication of the impaction. CT scan may be helpful for the localization of radiolucent object and for patients with suspicious complications such as perforation and peritonitis. The Masterclass defines the timeline for the endoscopy procedure for foreign body ingestion in children. They define emergent patient, urgent patient, and also elective patient. For emergent patient, usually we need to arrange the endoscope within 2 hours of presentation. For urgent case, we need to arrange the procedure within 24 hours. For elective patient, the procedure can be performed after 24 hours. How to determine the timing of endoscopy removal for this patient? The Masterclass have a very comprehensive table for us. The majority of this table indicate that the decision based on the type of injection, the clinical status of the patient, the timing of the patient last intake, and also the location of the foreign body within the GI tract. General anesthesia with endotracheal intubation is required in difficult cases to ensure airway protection, especially for young children, poor tolerance to procedure, multiple foreign body ingestion, and anticipated difficult extraction. Special instruments such as overtube, transparent cap, or flexible hood must be used to protect the mucosa during the procedure for the removal of short foreign body. Numerous retrieval devices such as forceps, basket, polypectomy snare, and also retrieval nets can be applied in children for the removal of foreign body in the GI tract. These are the common instruments applied for the foreign body removal for children, include the red shoes, alligator shoes, rose net, basket, grasper, transparent cap, latex protection hood, and also the overchill protector. Which device should we apply for this procedure? It depends on the size of the foreign body, the shape of the foreign body, the category of the foreign body, the length and operating channel within the endoscope, the shape of the child, the endoscopist's preference, and the habits. Which device should be applied? Foreign body retrieval forceps such as rat tools, alligator tools, shark tools are good for removal of disc-like foreign body, such as coins and button battery. Retrieval grasper is good for the removal of soft objects such as footballers, but not provide a secure enough grip for harder, heavy foreign bodies. Standard biopsy forceps is good for the removal of small and soft foreign body inside the GI tract. Basket is good for the removal of round-shaped foreign body. Polypectomy snares are commonly available in the endoscopy room and are relatively inexpensive and is good for the removal of foreign body with the size range from 10 to 30 millimeter. Retrieval nets are relatively expensive but are useful for certain type of foreign body removal, such as coins, button battery, and also magnet, and also for en bloc removal of large footballers. Let's talk about the category one by one. Button battery injection is quite common in children. There are several reported serious complications of button battery injection, which include tracheal esophageal fistula, esophageal perforation, esophageal stricture, vocal cord palsy due to the injury of the recurrent laryngeal nerve, mediastinitis, cardiac arrest, pneumothorax, and aortoenteric fistula. The greatest risk of complication are associated with young age, less than 5 years of age, large button battery, more than 2 cm, and multiple button battery injection. The flow chart from Nesbitt told us that in case the patient got a button battery injection, we need to arrange a plain film to locate the button battery. If the button battery is located in the esophagus and the patient is otherwise stable, we can arrange the endoscope procedure in the endoscopy room as soon as possible. If the patient presents with acute bleeding or unstable vital sign, the procedure should be arranged in the operating room with the standby of surgeon. Once the button battery is located in the stomach or beyond in children less than 5 and the button battery more than 2 cm, we should consider the assessment of mucosal lesion and also arrange the endo or enteroscope removal. For children more than 5 years of age and the button battery less than 2 cm, we can consider follow-up the patient with serial X-ray. Once the button battery trapped in the GI tract, we should consider about the removal. Magnet injection is also quite common. The primary risk is the potential hazard for enteroenteric fistula formation, bowel perforation, peritonitis, and bowel ischemia necrosis between magnets in adjacent groups of bowel. The increased complication rate of magnet injection in recent years include common use of neodymium or rare earth magnet, which have 5 times of attractive force as compared with traditional ones. Magnets in toys and also in other small objects. The flow chart from Nesbitt told us that in case the patient have single magnet injection and the magnet located in the stomach and esophagus, we should consider about endoscopy removal. In case the endoscopy is not available and the patient is also a low-risk patient, we can consider follow-up patient with serial X-ray. And of course, we need to offer comprehensive patient education to avoid further magnet object injection. Once the single magnet beyond the stomach, we can consider the arrangement of enteroscope removal or follow the patient just with plain X-ray and also inform and educate the family to avoid further magnet injection. In case with multiple magnet injection, once all of these magnets locate in the stomach or esophagus, endoscopic removal as soon as possible is recommended. Once these magnets are located distal to the stomach and the patient is symptomatic, we should arrange the surgical intervention. Once the patient is asymptomatic, we can follow patient with serial X-ray to ensure the passage of magnet through the GI tract. Sharp object injection is also common. The reported complications include perforation, extraluminal migration, abscess, peritonitis, fistula formation, organ penetration, rupture of common carotid artery, aortal esophageal fistula, and also death. The risk of sharp object-related complications are higher in patients who are symptomatic, delay in diagnosis more than 48 hours, and radiolucent foreign body. Tooth pick and bone injection are high risk of bone perforation and most common indication for the surgical intervention. The flow chart from Nussbaum told us that in case the patient have sharp object injection and the object is radiopaque, we should arrange the emergent endoscope for esophageal and the stomach sharp object for the removal. If the object is distal to the triceps ligament and the patient is symptomatic, we should arrange the endoscope or surgical intervention. If the patient is asymptomatic, we may just follow patient with serial X-ray. Once the sharp foreign body trapped in the GI tract more than 3 days, we can arrange the removal. If the object is radiolucent, the patient is symptomatic, we should arrange the endoscope for the check and also the removal of the sharp object. If the patient is asymptomatic, we should consider cross-section image to locate the foreign body. If the foreign body is located by the cross-section image, we should consider the endoscopy removal. If there is no evidence of foreign body in the cross-section image, we can observe the patient clinically. This is an 8-year-old boy who swallowed a needle during a dental procedure accidentally. At the presentation of our clinic, the needle was identified to locate in the cecum. So we arranged the admission because the patient is asymptomatic. After 3 days of observation, we find the needle still trapped in the cecum. So we arrange the colonoscope and we find the needle is trapped in the cecum bowel wall. We use the biopsy forceps to remove the needle from the bowel wall. Then we use the rose net to remove the needle from the GI tract successfully. Esophageal food impaction may also occur in children. Usually is associated with underlying esophageal pathology, such as eosinophilic esophagitis, reflux esophagitis, post-anastomotic stricture following reconstruction of esophagus, achalasia, or other esophageal motility disorder. So, for the removal of food bolus infection in esophagus, usually we need to arrange the biopsy of the esophageal wall to confirm the underlying disease. And also GI clinic follow-up is recommended in case the patient got further dysfunctional symptom sign. Esophageal function tests such as manometry may be recommended. The flow chart from Nussbaum told us that for the suspicious of esophageal food impaction, once the patient not tolerating secretion, we should arrange the endoscope in an urgent way. We should remove the food bolus and also take the biopsy of the esophagus and arrange the GI clinic for the follow-up of the patient. Coins are the most common ingested object among children. There are several factors associated with the likelihood of spontaneous passage of the coin, which include the position of the coin, the age of the child, and also the coin size. Risk factor of coin impaction include large coin more than 23.5 millimeter and young children less than 5 years of age. The flow chart from Nussbaum told us that once the patient got coin injection, we should take a plain X-ray. If the coin is located in the esophagus and the patient is pneumatic, we should arrange the endoscope in an emergent way. If the patient is symptomatic, we should arrange the endoscope in an urgent way. Once the coin is located in the stomach, we can arrange the follow-up plain film 2 to 4 weeks after the event. Once the coin trapped in the stomach after 2 to 4 weeks, we can arrange the endoscopic removal of the coin. In case the coin is located in the small bowel at the presentation, we just follow the patient clinically. Once the patient got clinical symptoms of bowel obstruction, we need to arrange the removal of the coin. This is the experience from foreign body endoscopy removal in UK. 239 admission of foreign body ingestion event were recorded. From this analysis, mucosal injury rate was account for 33% of this endoscopy needed foreign body removal event. So the rate is quite high. The item location was significantly associated with the mucosal injury rate. Usually, the upper esophagus is associated with higher risk of mucosal injury. And also, the presence of deep ulceration during the procedure are associated with glass item and also bottom battery ingestion. So this study told us foreign body ingestion is associated with high mucosal injury rate and should be avoided and managed properly. Ladies and gentlemen, let's come to the conclusion. Management of pediatric foreign body ingestion remains one of the most challenging endoscopy dilemma due to the lack of prospective multi-center trial to provide a strong evidence-based guideline to guide us for the management of all kinds of items in kids' bowel. So it's a very difficult issue to determine the timing and the procedure. General anesthesia with endotracheal tube intubation is required in difficult cases to ensure airway protection, especially for young kids, poor tolerance to procedure, multiple foreign body ingestion, and procedure with anticipated difficult extraction. And the timing, the choice of instrument device are largely depend on clinical symptom of the patient, location of the foreign body, size and the shape and the character of the foreign body in the GI tract. Thank you very much. I have done with my presentation.